Hi, I'm Sonu Jain, Hammer in Ilvi Cotterell, and I would like to welcome you to our brand new update series from the American Association for Hand Surgery. And we're going to be doing just that, updating you on the latest of what's happening in hand and upper extremity conditions. Today, we'll be discussing complex phalanx fractures revisited, what's new and what's tried and true. And it's my pleasure to introduce you to our moderator, Peter Reed from the Mayo Clinic in Rochester. Peter?
Thanks, Anu. Thanks to everyone joining live. Hand fractures are just so common to our practice, and there's a lot of different ways to treat these. But there are certain fractures that keep you up at night, and certain ones that make you think outside the box. But majority fractures that we can treat with traditional methods. Next slide. I think we have a really, really comprehensive program tonight. We're going to review a lot of different ways to treat fractures, and our very esteemed faculty tonight are going to go through kind of their indications and tips and tricks for when they would utilize these different methods of fixation for unique fracture patterns. So we'll first start with Dr. Joe Catapano from University of Toronto, assistant professor there in the plastic surgery division. So Joe, why don't you take it away with K-wires, fan favorite.
Perfect. Thank you very much. Can you all see my slides?
Yes, we can.
Perfect. All right. Good evening, everyone. Thanks for coming. As you mentioned, Joseph Catapano, I work in Toronto. So I'll get right into it. In terms of the goals of treating phalangeal fractures, we want to reestablish normal anatomy with anatomic reduction. We want to minimize soft tissue injury for the obvious reason of preventing scarring and maximizing early range of motion after surgery. And lastly, for that same reason, we want to provide a technique that allows early mobilization, when possible, which is the main argument for more invasive techniques. In terms of restoring anatomy, I'm very much guided by the principle that we're treating the hand and not the x-ray. So although my goal with K-wires is always a perfect reduction, I'm really trying to get them to an acceptable alignment. And to me, what acceptable alignment means is no scissoring, no extensor lag or minimal extensor lag, and reasonable fracture fragment overlap so I can ensure healing, which almost always happens if you don't disturb the soft tissues. And this is a theme that's very common in hand surgery. It's better described for metacarpal fractures, which have the benefit of the intercarpal ligaments to maintain them in the position that they're supposed to, but it also applies to phalangeal fractures, although you can't be as liberal with the displacement as they're quite prone to scissoring. To illustrate this point, this is a patient of mine with less than ideal fracture alignment. He's actually a family doctor that works in our healthcare system, presented late for care, and ultimately decided that he didn't want surgery. And he's done surprisingly well. Despite volar angulation at the fracture site, especially of his small finger, he has near complete range of motion, and he has an excellent outcome with no deficits, as he describes. The greatest argument against K-wire fixation is that they do not permit early mobilization. However, I do provide them some mobilization within a dorsal blocking splint. So although I keep their MCP joints at 90 degrees, I almost always allow them some short arc range of motion at the PIP and DIP joints. And I haven't found that this sacrifices their result in any way. It actually results to earlier recovery. And the main reason I prefer to use K-wires is I work in a public healthcare system. We have limited access to the OR, and it allows me to improve my OR efficiency and the cost effectiveness of the care that I provide. So I'll get into some cases. Some of these are simple. They will get more complex. But this is a classic scenario that I think is ideal for K-wires. It's a proximal phalangeal fracture with no articular component. They usually easily reduce with flexion of the MCP joints. So I reduce the fracture, and then I flex the MCP joints, PIP and DIP joints fully so that it stresses the extensor mechanism as much as possible. And then when I have them in full flexion of all their digits, I can ensure that the digit is properly aligned when they're making a fist. I then insert two anterior gate K-wires into the phalangeal shaft. And I often do these under local anesthetic so that I can get the patient to flex and extend afterwards under thoracoscopy. And I can look at how much motion there is under the fracture site, and I can ensure that they have good alignment. And here are the patient's postoperative films. This is another example of the same, just illustrating the same concept, two anterior grade wires, a near anatomic reduction. And I find that because I'm reducing them in flexion, again, I allow them to flex and extend their PIP joint within the splint, and so it allows them to recover more quickly. In this case, I wanted to highlight, well, most of these fractures tend to be epibasal. I find that often they're more comminuted than I initially expect, and there's often an intra-articular component when I take them for fluoroscopy, which you can see highlighted here. So it's actually a three fragment fracture. And what I do with these is under fluoroscopy, I insert the two anterior grade K wires into each fragment. And this allows me to joystick the articular fragments into position. I reduce them under fluoroscopy, and then I usually have the resident advance the wires while I'm holding the reduction. I think the K-wires are particularly ideal when you have multiple hand fractures, not just phalangeal fractures, because again, it allows you to increase the efficiency of the OR. And I become hesitant if I have to make multiple open incisions on the hand, because I think with that much soft tissue disruption, it increases the global swelling of the hand, which ultimately increases scarring and reduces the range of motion afterwards, even if you allow for immediate active range of motion. And so here you can see that even though the wires are not in the ideal position, and the reductions may be a little bit better with an open reduction, it's adequate enough that they're going to have full range of motion afterwards because there's no scissoring or extensor lag. And most importantly, I've improved and corrected that volar apex angulation that you usually get with these fractures. This is a patient with a D5 proximal phalangeal fracture from a gunshot wound where there is extensive comminution and soft tissue disruption. And I do agree that there's some advantage to getting these patients to move more aggressively initially. But I'm concerned that sometimes I'm going to end up getting a non-union and ultimately have to go in there and put in some sort of graft. And so I'd prefer to get these patients in the appropriate alignment with K-wires, get them moving through that short arc range of motion. And then if I need to do a surgery in the future, I've at least not gone through that wound a third time between the bullet and myself and then my revision surgery. And so here, as I do in a similar fashion with other fractures, even if they're heavily comminuted, I ensure that the digit is in the proper alignment by flexing all of the fingers. And so with the small finger aligned appropriately with the D4 digit, in flexion at the MCP joint, the PIP, and the DIP joint, I insert those two anterior grade K wires and ensure that at least when they're making a fist, the digit's not going to be scissored. I then move them under the fluoro, and if I feel that the fracture fragments are adequately aligned and there's not much motion, I still will allow them some range of motion within the splint, which can at least help move their flexor tendons so they don't become adherent. This case, and again, I apologize, I don't have the pre-op films because sometimes they're at different health centers, so I don't have access to them. And so I just reassess them under fluoro. But with this patient here, I find K-wires particularly useful for unicondylar or bicondylar neck fractures. And the reason is that you can put those wires in and again, use the wire as a joystick to get a good articular alignment before you drive that wire across. Whether it's bicondylar or unicondylar, I always put at least two wires because there is some rotational deformity there that you need two K wires to correct and ensure that you prevent rotation afterwards. This was a thumb fracture, which usually do quite well even if you immobilize them for a long time. But after reducing the articular surface, I then put two retrograde K wires to ensure that that the shaft of the proximal phalanx doesn't collapse while it's healing. And I'll usually keep these wires in for 6 weeks. I don't provide them much motion, but like I said, the thumb recovers quite well regardless. I also tell patients, and so I don't have a lot of x-rays 3 months or 4 months after surgery or even after surgery at all, because I often tell patients that if they don't have any concerns and they're happy with their hand, then the x-ray is not going to change any of my decision making. And ultimately, it can only disappoint us both. So I don't get them unless there's an issue, and it saves our public healthcare system a little bit of money. In this case here, again, it's a proximal phalangeal neck fracture. And the point that it's meant to show is you can see how that first retrograde K wire is bending. And that's because I put that first wire in and I used it as a joystick to get the fracture properly aligned. And once it was in the shaft, I then advanced the wire while it's in the shaft, which allows it to bend. And then supplement that reduction with a second anterior grade K wire. This case here is similar to what I've showed previously, but is ultimately just to show that I do sometimes use a clamp for these fractures. So similar to what you would do in an open fashion. I put the clamp through the skin to get an adequate reduction. I ensure I have that on fluoroscopy, and I'll then advance 2 wires to maintain the reduction. A lot of my photos, when I look back at them, are from proximal phalangeal fractures, but the same principles apply to middle phalangeal fractures. The one thing that's unique about middle phalangeal fractures is I find a lot of the patients that I get have just smashed middle phalanxes with intra-articular components. And I really don't have a great way to treat these except for dynamic external fixation, which I do exclusively with K-wires. And so you can see this gentleman here has what we call the high exiting pilon fracture of his D5 middle phalanx. And so I take these patients under fluoroscopy. I reduce them with traction utilizing ligament ataxis. I insert 2 K-wires, one into the proximal phalangeal head and the middle phalangeal head, and then bend the K-wires to make a gall-type external fixator. Depending on whether there's still some dorsal or volar displacement of the joint, then I will add a 3rd wire sometimes, which allows me to create a volar force to get a little bit of a better reduction. And I send these patients immediately to therapy after surgery so they can start early active range of motion exercises. And you can see how much tension those wires are in by how bent that 3rd distal wire is. This is the patient 3 months after surgery, and I agree the x-rays aren't perfect, but I'm not sure that I would have been able to obtain any better of a reduction with any other technique. And ultimately, the patient's quite happy. And interestingly, they usually end up with excellent range of motion of their PIP and worse range of motion of their DIP joint because of the swelling after surgery. If they have good passive range of motion, better than their active range of motion, then I don't hesitate to do a traction tenolysis, which I do wide awake by opening the flexor mechanism proximal to the A1 and pulling on the FDP. This is another example where I didn't use a 3rd wire and obtained a fairly good reduction. I also tend to use these for volar plate avulsion fractures with dorsal displacement. The reason I included these is because although she ended up with an excellent reduction intraoperatively, and she was actually an occupational therapist that works with our group, I placed a 3rd wire and I put far too much of a force, giving volar displacement. And so when she came back a week later, she actually had a volar dislocation of her PIP joint. So I pulled that 3rd wire, did a manipulation in clinic, and she ended up reasonably better aligned. And again, not a perfect reduction, but I think because we start that early active range of motion and she's still under traction, she has full range of motion now, which is painless, fortunately, because I have to see her all the time. So again, the goals of treatment, again, acceptable alignment. I think K-wires are great for minimizing soft tissue injury. And so oftentimes the worse a fracture is, the less likely I am to open it because I'm concerned that I'm going to devascularize those fragments and increase the risk of complications and adhesions. But I do admit that they're not going to provide you as much active range of motion and return to work as some other techniques. But again, I do provide them short arc range of motion within a splint that keeps their MCP joints at 90 degrees. So they do recover quite quickly after surgery. And I would say probably 8 to 10 weeks after surgery, most of the patients have almost full range of motion. And I do use other techniques when necessary, and I'll leave that to the other speakers to discuss. Thank you very much for your time.
That was fantastic. Thank you. I think K-wires are a fundamental method of fixation for all of us, especially in trauma and soft tissue, associated soft tissue injuries. So that was great. And I think you really nicely illustrated that just because you're using K-wires doesn't mean that you ignore the principles of fracture fixation and alignment and reduction. So I think that was fantastic. Thank you very much. We're going to save questions at the end. We have a small chunk of time there, but please utilize the chat function if you have any questions, and a lot of the speakers will try to answer those questions as we keep moving forward. Plates and screws, also a very integral part of our practice in treating phalangeal fractures. We have Dr. Chelsea Bowe from University of Washington. Excellent surgeon. I know that firsthand when we work together. So Dr. Bowe, take it away.
Thanks so much, Peter. Let's get shared here. Is that looking good to everybody?
Perfect.
Wonderful.
Let's see. Oh, full time. Switch to your. We're seeing presenter mode.
Oh. Wait. Cancel. Apologies. Sorry, guys. I don't know what's going on here. You're not seeing anything now, correct?
No,
Okay.
not yet. Is it frozen, Chelsea? Because if it is, we can
I'm so
leapfrog you
sorry.
and come back. That's okay.
Try this one more time here.
I feel good about this. Yes, perfect.
Looks good now.
Mm-hmm. Perfect.
Okay. All right. Sorry about that. So, as you read in my notes earlier, tonight my charge is the tried and true plate and screw fixation for phalangeal fractures. So, we're going to do a couple representative cases, cover some of the data, and then go through some tips to optimize outcomes in these challenging fractures. So, thanks to Kevin Malone and Kim Mesra, who shared some slides and inspiration with me after a recent AO webinar. I like to start talking about phalangeal fractures with a reminder that nowhere in hand surgery is it more important to avoid the concepts of never and always. There are many ways to fix phalangeal fractures, all of which you should be familiar with and comfortable to any hand surgeon. Numerous considerations go into the thought process of how to approach these, and there's absolutely no panacea. There are numerous factors that influence the outcomes of these fractures. Some of these we can control and some we cannot. Patient factors are out of our hands. Fracture factors are out of our hands. Where we can make a difference is in the management. This includes recognizing the injury, managing the soft tissues, reducing and maintaining reduction of the fracture, immobilizing and mobilizing appropriately, and then identifying and managing complications. I would argue one additional aspect of management that may or may not be out of your hands is the timing of both the presentation to your clinic and the timing for intervention. This can absolutely alter how you manage a fracture and how it needs to potentially be approached. So we'll start with the case. This is a 21-year-old male. He's a college student. He's an engineering student. And he actually presented to me 3 weeks after a basketball injury at the behest of his father. He didn't want to seek care because he had an important test coming up and he didn't want anything to impact it. So this is AP film. You can see this oblique fracture type, but the real key for this patient is the clinical exam. So he has obvious malrotation of the digit. Clearly, this is something that you need to fix, but the question is, how do you approach this fracture? So this fracture would be considered a long oblique fracture, according to the classic article and description by Jones, Jupiter, and Lalonde, in which a long oblique is defined as a fracture length 2 to 3 times the diameter of the bone at the fracture site. Lag screws can be used with sufficient rigidity to allow early range of motion with minimal hardware interaction with the soft tissues. Screws should be placed a minimum of 2 diameters from the apex to avoid propagation and fragmentation. Screws placed perpendicular to the fracture site are excellent at resisting torsional stresses, whereas screws placed perpendicular to the long axis of the bone resist axial forces. Thus, multiple lags accomplishing both tasks are preferred, and hence the recommendation from that classic article to place the screws partially between the long axis of the bone and directly perpendicular to the fracture site. Taking in the account of the spiral nature of these fractures, your screws really never should be parallel. Screws should be placed or may be placed in a lag by technique fashion, but can be just as effectively placed as interfragmentary screws with externally applied compression, and you're not losing strength by using that technique. So a reminder, parallel is cute for parking, not for screws. Back to our fracture. So long oblique that's absolutely amenable to screw fixation and early range of motion. You can make an argument for pin fixation, but I mentioned earlier the delay in presentation in this young, healthy patient, which is part of why when I look at this and hear the story, I'm anticipating needing an open approach to take down the callus and obtain a perfect reduction, correcting that malrotation. When the fracture is then opened for reduction, I'm in favor of rigid immobilization so that you can really be aggressive with your early range of motion because we anticipate increased soft tissue disruption and the potential for adhesion formation. Anticipating the orientation of these screws, the fracture was opened laterally. It was provisionally fixed with K-wires placed with some external compression. And note the wires are not parallel. They follow that spiral of the fracture. They're neither perfectly perpendicular to the fracture nor perfectly perpendicular to the long axis of the bone, somewhere in between. I always keep this table close at hand to recall what size K-wires can be used as a drill. I remember this usually as just remember 4515, and then you work up and down from there. This avoids the additional step of drilling, especially when you have a tenuous reduction, limited real estate, which is essentially just a phalangeal fracture. So in this case, the wires are replaced with screws. You can countersink to avoid prominent screw heads, but I frankly don't very often for such small screws in this place. The technique is really of paramount importance for these fractures with these small screws. I will occasionally excise a little bit of lateral band if it interacts with the hardware, but for screws like this, I don't often do that. And then after a short period of soft tissue rest, a few days, they start moving under the direction of hand therapy. And here he is at 12 weeks when he got released to unrestricted activities where he's radiographically and clinically healed. His motion, he was lacking 5 degrees of extension. He was nearly approximating his DPC, and it was continuing to improve week by week. So we'll move on to another case. So this is a 24-year-old male. He's a construction worker. He presented after a run-in with a metal grinder while he was at work. For this specific discussion, we're really focusing on the index P1. So you can appreciate the spiral component that looks a little similar to the long oblique we just demonstrated treating with screws. But in this case, if you scrutinize that AP, you can appreciate there's some comminution. And if you follow that spiral, there's some intra-articular extension, or at least the worry of intra-articular extension. So in this case, I'm thinking more about a plate. So indications for plating they include, not limited to, need for an open reduction where you have comminution of the fracture, periarticular extension. If you need a rigid construct, which usually for me is a patient factor question, then I'll start pushing towards plating. Again, these are all relative indications. Always and never aren't really words in this vocabulary. People ask, does the position of the plate matter? And of course it matters. Thinking about the anatomy of the digit and the structures that need to glide around the phalanx, hardware placed in the interval between the extensor and the bone would seem to obviously increase the risk of stiffness. We know from our knowledge of implants that rigidity of the construct is dependent on the position of hardware relative to tension and compression sides of the bone. Plating is an incredibly rigid construct for fixation of phalangeal fractures, a fact which has been demonstrated with numerous biomechanical studies. As expected, the surface of the bone that you plate does impact ultimate load to failure, with dorsal plating being the strongest construct, more resistant to bending forces than a laterally placed plate. The position of the plate and risk of stiffness is a little bit less clear in the available published data. A study from 2008 demonstrated significantly better total active motion with lateral plating, which has been reproduced in a more recent smaller study. But another review failed to demonstrate that same outcome. The retrospective nature of these studies is an obvious limitation, as the fractures that are plated laterally are entirely likely to be different than those plated dorsally. There are no randomized controlled trials that I'm aware of comparing those direct outcomes. It's intuitive that avoiding a plate directly under the gliding extensor mechanism would decrease your risk of adhesion and thus improve the potential for recovery of range of motion. So this is consistently recommended when feasible based on fracture factors. Complications of plate fixation are frequent. This review of plated phalangeal and metacarpal fractures, published by Peter Stern, paints a bit of a disappointing picture of plate fixation. He demonstrated an overall 60% or nearly 60% complication rate, but this was significantly higher for phalangeal fractures, where 92% had one or more complications, and 56% were major, so significantly compromising function or requiring additional procedures. It's clear from his data that fracture factors play a role in these complications, and it really speaks to the nature of these injuries in general. Stiffness is a frequent finding both in this study and in general with the treatment of phalangeal fractures. It's really less a complication, more an expectation. Several patients in that study underwent additional procedures to improve range of motion, but even with tenolysis removal of hardware, normal function is by no means guaranteed. So doubling back to our young man with the metal grinder, I chose to treat this with a plate. The comminuted P1 fracture, I went lateral for this. First, a provisional reduction with K-wires, then the plate application with excision of the overlying lateral band. This doesn't compromise any mobility and improves it because it doesn't adhere to that plate. Again, this is a really rigid construct, lateral or dorsal, and so early range of motion can be undertaken. And then here he is at 16 weeks, clinically and radiographically healed. Amazingly, at 16 weeks, his grip strength was equal to his contralateral side. He had unrestricted return to full construction duties at 5 months. Subjectively, his index finger, he felt a little stiffer, like it took a little bit longer for him to recover range of motion, but by the time he was released, he couldn't really distinguish either. So the take-home points for this, if you must open, fix it rigidly so you can move them immediately. Use screws for long obliques and make sure they're not parallel. Plate comminution and articular fractures. Open laterally and plate laterally when that's possible. Therapy, therapy, therapy. And then I would say talk about tenolysis early. And then one last plug that's not really mine to say, but I still say perk if you can perk. Use an IM screw if you can IM screw. And then remember all of this if you're using plates and screws. Thank you.
Thanks, Chelsea. That was a great talk. There are many things that bring me joy in hand surgery. One is anatomic reduction and something that's just so rigid that you can move them comfortably without losing sleep. So I think there are some good pearls there and a lot of good things to know about some potential complications, but you can certainly mitigate those with a lot of the tips that Chelsea presented. I think the biggest innovation in the area of hand fractures, in particular metacarpal and phalangeal fractures, are intramedullary fixation. It's in vogue, but rightfully so for the right type of fractures. We have Dr. Mihir Desai from Vanderbilt University. Right, Mihir?
Thank you. All right. Can you see that okay?
Yes.
Perfect. So thanks, Peter. Yeah, I agree. These intramedullary fixation techniques and devices have certainly become the new kid on the block, very popular. Most companies are trying to come out with something that serves this sort of growing need and use. So I'll kind of highlight some of the salient points about this technique, as well as kind of give you my own opinions about it. Here are my disclosures. So we'll start with a case. This is a fairly similar fracture to what we've seen in the past couple talks. Very common base of the proximal phalanx fracture with that fairly textbook dorsal angulation, may even be a little bit of intra-articular extension. And as most of these are slightly comminuted right at the fracture site. So as we know, as far as our treatment options, we have several. If the patient doesn't have much of a clinical deformity, they're low demand, they have reasonable range of motion at the time of evaluation, we could elect to treat these non-operatively. As we just learned, pins and plate and screw constructs are also excellent options. But more recently, the advent of the IM nail has really pushed several of us into trying this technique. So when we look at what intramedullary fixation is, I think it's important to sort of understand the definition. Okay, so this is an intramedullary implant, and most intramedullary implants, at least in the orthopedics world, came from long bone fixation. So femur and tibia fractures that are really begging for intramedullary long bone stabilization. And phalanges are not long bones. They're unlike the metacarpal, right alongside the growing use of intramedullary fixation for phalanges have been metacarpal fractures. And as we, I think, all can agree, the metacarpal intramedullary fixation tend to be really great options for most patients. They work well. It's a long bone that can be stabilized effectively with a single implant. So when we try to extrapolate that technology to phalanges, there are some similarities, but they're not entirely an apples to apples comparison. Now, the pros of using an intramedullary implant for a phalanx fracture is the earlier range of motion than pins. There's sort of this mantra that a lot of us will talk about when we're thinking about using these, and it really comes down to the idea that if you can pin a phalanx fracture, then you can nail it. So it's almost as if you're using these implants interchangeably. So, for example, if you've got a construct like we see on the image here on the screen, if you can place K-wires in this configuration to stabilize the fracture, then you can just pass a cannulated intramedullary device over those pins. Now, again, since we can allow earlier range of motion with these implants, since they're completely intraosseous, intramedullary, there is theoretical less stiffness. And I've put an asterisk here because I think if anybody has used this technique, they have certainly had their own patients where not all of these patients do as well as you would think as far as range of motion. And sometimes our K-wire patients actually outpace these patients in their return to full range of motion. Now, if we look at the negatives with this technique, I think the big one comes down to cost. The implants that we see here on the right, the same construct with a couple K wires for each finger would run us about $24 at our surgery center versus a $2,000 construct for 4 of these intramedullary implants. So the cost is certainly a big negative for this technique, especially if we can't 100% reliably predict that these patients will get a better outcome. They can also be very difficult to remove. If you've ever had to take one of these out, you know that once these are in, they're very tough to back out or advance back through, and can be quite destructive in that process. And as I mentioned before, these patients can still get stiff, which again is the very much the theoretical benefit of this technique. So back to our case with this patient, for the proximal phalanx fractures, I did for this one particularly elect to do an intramedullary fixation. So again, I use this idea that if you can pin it, you can nail it. So we get our reduction, and we use the guide wires that come with the instrumentation kit. And if you think about some of the technical pearls with this, when you're inserting an intramedullary implant, you can insert it either antegrade or retrograde. My preference tends to be antegrade so that I can avoid violating the articular surface within the PIP. But as we just saw in that last talk, a retrograde implant is certainly a good option. There's growing data that those patients don't actually have lots of complications by splitting the central slip and entering the PIP. But I do like an antegrade placement of these implants. If I'm going to do that, I'm going to try to get both guide pins in before placing my screws. Again, if I can stabilize the fracture with my guide pins, then advancing these nails or these screws is much easier. And then I think it's important to accept any stable configuration. And what I mean by that is you let the anatomy of the phalanx determine what your nail orientation is going to be. I showed you in the last image a patient that had 4 implants in their hand, and we used a lambda construct. This is more of an A construct, and then if they've got a larger phalanx, you can actually do an X construct where the 2 nails are crossing one another, and you get a little bit of interdigitation of the threads of the nails, and it can actually lead to a very rigid construct. So I'll basically try to accept any stable configuration that I can if I'm going to do this technique. So this is a patient that ended up with the A construct. So 2 intramedullary fixation implants. The one thing I did point out in that last slide is the exit point for the guide wires. Most of the techniques call for double penetration of the phalanx, so penetrating it on the proximal side or the antegrade side, and then you have to breach the cortex distally at some point. And where you breach the cortex, it can either be either radially or ulnarly or dorsally. We try to avoid going volarly, obviously, because you're going to impact the flexor tendons, and you don't want to enter the PIP if at all possible if you're going to go from an antegrade approach. So this is a patient with the A construct with 2 intramedullary implants at their early follow-up, and then this is later once they've healed. And these patients start early range of motion immediately if they're regardless of how motivated they are. I'll start formal therapy, but the really motivated patients can usually work their way through therapy fairly quickly since we're allowing range of motion immediately. So here's another case. This is a slightly more distal fracture. And we can see that it's treated with, again, 2 antegrade intramedullary fixation devices. that are crossing the fracture site and exiting in a X configuration. And I apologize for that ringing. I don't exactly know where that's coming from. And then here's the patient once they've fully healed, roughly 6 to 8 weeks following fracture fixation. So 2025 was a big year for a couple studies looking at these. There were actually 2 that came out in hand this year. They were both retrospective reviews. This is one that looked at intramedullary nailing versus K-wires. And in the intramedullary nail group, in this particular paper, these patients had a quicker return to active range of motion, a shorter duration of orthosis treatment, fewer overall OT visits, and improved range of motion at 6 weeks compared to the patients that were treated with K-wires. And then the complication rate between the 2 groups was similar, which I found interesting. There wasn't, a difference in, for example, pin site infections and things like that. These patients tended to over across both groups have fairly similar outcomes. Similarly, another retrospective review from this year showed that patients with IM nails had improved total active motion and overall PIP joint motion at their final follow-up at 12 weeks. But the quick dash scores were similar. So even though the patients had some improved range of motion relative to the K-wire patients, the quick dash were similar in both groups. Now, I mentioned earlier the difficulty in removing these. So as this technique becomes a little bit more widespread, and as we're doing more of these, papers like this are necessary to give us an idea of how to have an exit strategy just in case we run into complications. So I think it's interesting that this technique, as it continues to become more widely utilized, we've got growing evidence and data and guidance to manage some of the complications that we might see with these, because they are certainly different than a plate and screw construct and simple K-wire fixation. So in conclusion, IM nailing of proximal phalanx fractures is safe. There are some early benefits in range of motion, but again, the most important thing here is to weigh the pros and cons based on cost and whether these patients can predictably have one of those really great home run type outcomes by allowing that immediate range of motion. We certainly need more prospective data. All of our data currently is retrospective reviews. And as I mentioned earlier, anecdotally, a lot of these patients can still get stiff. So it's even though you're using an intramedullary implant for a phalanx, you're not completely avoiding the risk of stiffness, which is something that I think all phalanx fractures are sort of at risk for. Thank you.
Here, that was awesome. I think that with any type of innovation, if you look at like the Gartner hype curve or cycle, there's always a lot of enthusiasm, but then as people start using it, you start defining kind of the guardrails of what the best indications are. So I think you gave a really nice comprehensive review, but also somewhat cautiously too. So I think in your practice, to everyone listening and watching, you just have to find what works the best for you. And it's certainly challenging, but definitely once you understand some of the tips and tricks, I think it's a powerful tool. So thank you very much. There's a question, there are a couple of questions in the chat. Thanks for lighting that up. So please, I encourage you to ask our speakers any questions, but we'll move on to an area that is a method of fixation that is somewhat traditional. I mean, it's external fixation that's used in a lot of fractures, but you can get quite innovative with it too. So we have Dr. Cha Wu from Houston Methodist Hospital.
Okay, can everybody see my slides?
See, go to perfect. Looks good.
Does that work? Okay. Well, thanks for the opportunity to speak to you all. My name is Cha Wu. I'm from Houston, Texas, here at Houston Methodist. The previous speakers have covered really well. In fact, the first speaker did mention external fixation, and I'd agree with the question in the comment section that Usually I recommend 0.45 or 0.45 as well. The point made about the 9-inch long K-wire is actually pretty critical because if the traditional ones that typically come in the set usually is about 7-inch long, and other times you can, depending on what kind of construct you're trying to create with the K-wire, the 7-inch long, sometimes you run out of length. So that's actually not a trivial point. And ideally, at least for me, another tip is that the double-ended ones that's sharp on both ends usually helps me as well. So to get into this case, this is a case of mine, 60-year-old HVAC technician, fell on his left middle finger on exam, PIP very swollen, with 10 to 30 degrees of active range of motion. So this is a manual worker with a pretty bad fracture pattern. So this is almost like a combination fracture pattern. So when you look at it on the lateral, you can see there's dorsal displacement and there's a large volar piece with a high exiting fracture line, metaphyseal very distally. So it's behaving like a dorsal fracture dislocation of the PIP. But at the same time, there's fracture lines multiple in multiple planes extending dorsally. So in that regard, it's also behaving like a pilon. With this amount of comminution, there is consideration, whether it's going to hold plates and screws, to use K-wires, and traditionally this is being a difficult fracture to address with a, very difficult outcomes. So to go over the options that some of the previous speakers have addressed, you have different choice of fixation, different constructs, plates and screws, intramedullary nails. The goal really just comes down to in what combination can you achieve anatomic fixation that allows for early range of motion that is stable, as biologically friendly as possible. Specifically also to the PIP, what will allow you to restore a congruent joint with a smooth arc range of motion. Because even if the joint surface is not, perfectly reduced, if there is a smooth arc of motion and restoration of joint, like a congruent PIP joint, oftentimes the joint can remodel over time as well. X-Fix comes in two flavors, static and dynamic. And static flavors of this, which I'll go into some in a little bit, usually speaking, I would recommend for soft tissue contractures. Oftentimes they're quite useful. If there's severe soft tissue contaminations, you think about coming back with multiple visits, multiple washouts could be useful. But in the fracture setting, oftentimes we like to use the dynamic external fixator because it allows for range of motion early on, especially if you're able to do it in a way that that gives you a little bit of distraction and you can actually correct for deformity. Mainly just for these highly comminuted lengths unstable fractures, referring specifically to pilon, dorsal fracture dislocation is the most common indication. With a K-wire, you can actually allow for maintenance of length, alignment, rotation, early range of motion. Unlike some, we mentioned cost, Dr. Mihir's slide, that these are usually pretty cost effective, especially if you're in an austere environment. The static flavors of this on the left that you can see, you can actually make it pretty cheaply with just a syringe and PMMA cement and just K-wires. There's also pre-made ones by the company that allows you to dial in some degree of distraction in the lower left-hand corner. And the dynamic X-Fix on the right-hand side, as you can see, it comes in a couple different configurations. There's been a lot of different configurations published in the study, but they all really come down to a couple basic principles. So the first one is popularized by Dr. Suzuki, Dr. Slay, and external fixators. The principles are the same in that there's fundamentally comes down to two separate wires, typically one wire in the head of the proximal phalanx and one wire in the head of the middle phalanx. And these two provide 2 points of fixation. And then there has to be a power source typically. In this case, you can use a rubber band, and there's also an all-metal construct that the first speaker introduced that you can use. So it's important to insert these on perfect laterals because if the two K-wires that you insert are not perfectly aligned, that can actually introduce deforming forces and actually make things worse. So these are actually technically quite demanding procedures. Another pitfall commonly seen is that if when you bend the wire, they're not of equal length, you can actually introduce unequal tension and cause malalignment as well. So as you can see, and then another modification is that you can actually introduce a third wire. And the reason for introducing the third wire is that you can actually use it to introduce volarly directed force, or in some cases dorsally directed force if you're looking at a volar fracture dislocation. And this is frequently useful just because you can bring that the dorsal cortex more in line to create that congruent joint. There's an all metal construct. In this case, you're using the natural bounciness in the middle of the K-wire to serve as your power source to provide a distraction. So very similar to the other one, except you're trying to generate the power through the natural bounciness, the springiness inside the K-wire. And typically these are 0.045. So coming back to our original case, I elected to fix this with a all metal construct. As you can see right here, a little bit of distraction. In this case, to be critical, I probably would have liked to get a little more length. For these, in terms of post-op protocols, I typically recommend a soft dressing and immediate gentle active and passive range of motion with access to therapists as soon as possible, with a planned KY removal usually 4 to 6 weeks post-op. But certainly, like any other techniques, there are complications. So specifically in my case, you can see that the all metal construct, research-wise, has been shown that they can uncouple and that can introduce a deforming force. As you can see, you're requiring the metal, the bending of the metal to provide, making sure that the two wires are engaged. Other complications that's been published, including pin track infection, which can introduce osteomyelitis, which is also suboptimal. Uncoupling we saw in the previous slide. Over distraction is also common, and that certainly can contribute to extensor lag by changing the balance of force between the extensors and the flexors, especially typically used with a metal rubber band construct. It's hard to sometimes control depending on the length and the choice of rubber bands to make sure that you're distracting just the right amount. Of course, post-traumatic arthritis, there could be persistent malalignment, and especially could be quite bulky, especially if you're using this technique for non-border digits like middle and ring finger. Sometimes the ends of the wire can poke into the bordering digits, and that could be quite bothersome for patients. As far as the outcome is concerned, the most recent paper based on a literature review actually comes from the journal Hand in 2021 that was published, where they did a systematic review when they looked at over 2,000 articles, ultimately 48 met eligibility criteria, and they grouped them into 5 categories. Open reduction, percutaneous fixation, dynamic X-fix, extension block pinning, and hemi-hemi and these include both, dorsal fracture dislocation as well as pilon type injuries. Essentially, what they found is that the choice of technique in these systematic review didn't seem to matter too much. They did find some trends, though, that the perc pinning seemed to have the best range of motion. Extension block pinning seemed to have the best grip strength, but the author concluded that no one method is definitively superior. So I think it's fair to say in 2025, it's the choice of fixation is still depending on the surgeon and the specific fracture pattern that's at hand. In summary, I would say consider external fixation in the context of phalanx fracture, specifically for fracture dislocation of the PIP. I will consider for pilon types. These are I think the best indications in the setting of phalanx fractures. Consider the choice of metal versus metal rubber band construct. With the metal one, you have to be concerned about uncoupling as a potential complication, and over distraction sometimes can be common with the rubber band construct. And just remember that whatever method you choose, just make sure that it's the most stable, most biologically friendly, and most anatomic fixation you can achieve regardless of methods. So sometimes you even have to mix techniques to achieve that. This is one of the other techniques using the K-wire that I've had pretty good luck in. In this case, it's a dorsal fracture dislocation, and you can see you can use a perc technique to try to reduce the fracture using a clamp, and then 2 small K-wires to reduce the fracture, and then 1 dorsal block pinning. So I've had pretty good luck with this technique too. That's pretty much it for my talk.
That's great. Thank you. It really illustrates how you can get really creative with K-wires, especially for these challenging periticular fractures. So thank you very much for your tips and tricks. Our final speaker is going to go over the use of spanning plates, which I think is it's innovative in the sense that we don't think about it very much for complex fractures across the joints at the PI or the interphalangeal joints. But I think a very, very good tool. So we have Dr. Con Ozer from University of Cincinnati.
Thank you, Peter. Can you see my screen?
Yes, looks good.
Yeah, as you said that you're not thinking about spanning plate as often as maybe you should have, but I hope you don't have to, because I'm going to present this as the last resort, meaning that say you try K-wires, you try intramedullary fixation, plate fixation, or whatever else that you think works best in your hands. If it's not working, the last resort is this one. And what I'm going to talk about today is nothing new, really. Oops, sorry. Yep. Bridge plating or spanning of joint or a straight bone is not new. As we all know that we commonly have used this for years for distal radius fractures, particularly comminuted ones when we don't want to deal with the intra-articular fracture components. There's too much comminution. Or we also dealt with this in cases of open fractures with bone loss for staging, as in vascular technique. We also use the bridge plating for diaphyseal, metaphyseal, comminuted long bone fractures. And then finally, more recently, we started using this other parts too. I use bridge plating sometimes for complex elbow fractures, in addition to MP and PIP joints. And today I'm specifically going to focus on the PIP joint itself. So what are the pros of bridge plating? It maintains the length, stabilizes all the small fragments, allows soft tissues to heal, particularly the ligaments, hopefully. And the best thing is it's still an external fixation, except it's under the skin. In other words, during the bridge plating, I would recommend using a locking plate, in which case that you would still be using a form of external fixation, except not being exposed, and therefore avoiding all the complications associated with the external fixation, as the previous speaker talked about. The cons of bridge plating, obviously it requires a second surgery for its removal if you wanted to give motion. Obviously, stiffness and instability are probabilities, but stiffness can be avoided with a smart application or yet another application of Valant surgery. So my index case is a 45-year-old female accountant presenting with this particular fractured pattern. And when you look at this, what you see is an enchondroma. And the fracture and the injury that's leading to this fracture is essentially quite trivial. And she doesn't even realize at the first time that she had actually fractured it. She started seeing her finger getting swollen and somewhat deformed. And before we get the x-ray, we saw this right after this, saw the enchondroma. Which is a difficult situation. So all these speakers previously have talked about traumatic injuries leading to fractures, but sometimes fractures are pathologic fractures. So if you really delve into the details of this fracture, that you would realize that this juxta-articular position of the tumor eat up also entire subchondral bone. And when I get the CT scan and later on intraoperatively, counting the fragments in particular, in the CT scan, I realized that there were about 9 pieces of cartilage that was countable. So this is a very difficult situation. In this particular case, I had nothing to lose. Perhaps any other reasonable hand surgeon would have offered this patient a PIP joint fusion. But I went ahead and said, well, we can maybe bridge this gap by lengthening this and trying to remodel the joint surface as well to see if we can bone graft behind it. So this idea, the patient went and see another senior surgeon in town and came back again and say, okay, I want you to try. And intraoperatively, there are some important principles that applies not just to pathologic fractures, but all of them. And number one is it's best not to open the fracture site, because these are by definition pilon fractures that are comminuted, multiple fragments in there. And if you were to try to open and try to put them together, if they're large enough, go for it. But if they're too small, then you'll probably be really ending up with a disaster there. And it's best just not to open the joint. In fact, joint capsule and ligaments around the PIP joint will allow you to perhaps indirectly reduce some of those components. So therefore, it's highly advisable not to open a fracture. Now, the second thing to do is that I usually bend the plate, but later I publish my paper. I've seen others just putting straight ones, which is fine. There's nothing wrong with that. The reason I bent the plate about the functional position of this particular PIP, less on the index, more on the small finger side, is because if somehow the patient doesn't restore the motion, at least that it stays in that position, which is a functional fusion angle. So in this particular case, about 40 to 45 degree plate bent, being placed right over the extensor apparatus. And what you see here on the right-hand side is that you put the screw holes without really making any more dissection, just a poke hole, and splitting the extensor tendon right at the dorsal and the proximal phalanx, and then placing your plate. Important thing is that while you're placing this on this lateral plane, it doesn't show exactly, but it's best to put your freer right under the plate to keep that distance intact so that there is some space for the extensor tendon to breathe in. Now, if you go ahead and put the plate directly over the extensor tendon and put a normal cortical screw on it and crush that extensor tendon down to the phalanx, it's unlikely that this tendon will recover and glide. So therefore, you'd be automatically creating a significant crush injury to the extensor apparatus. It's best not to do that. Now, in the next step, obviously, the patient goes away 4 to 6 weeks later. Once you see initial signs of healing, then you go back and remove the plate. In this particular case, I will go back to this initial picture again. This forceps that you see that's sitting against this empty hole is actually the little window I created to pack some additional bone graft into the enchondroma site. Because enchondroma needs to be in fact first threaded out, and in addition to that, also the bone graft needs to be packed in. And through that window, I was able to indirectly reduce the fracture inside PIP joint. So the joint lined up better as a result of this bone packing, as you see in this picture. This is intraoperative in the first surgery. Now you come back 4 to 6 weeks later, depending on the age. Younger, closer to the 20s, is 4 weeks. Closer to 60s is 6 weeks. You go ahead and remove these screws and plate. In the meantime, you do some full capsular release in the PIP joint, including the collateral ligaments as needed. In fact, it's best to perform this surgery so that you see if there's any flexor tendon adhesions or extensor tendon problems, or the joint itself is causing the stiffness. That way you would be able to address those on the same setting. After that, as one of the previous speakers have said, therapy. This is the patient's result after 6 months. The video here hopefully plays to show what's going on. There you go. As you see, the IP joint is quite stiff, given that the lateral bands crossing the PIP joint are probably stretched and very difficult to really mobilize. But given where we started, the kind of fracture that we had, I think this is a reasonable result without a fusion. All right. Now, this is an example of a spanning plate of the MP joint, which is a 29-year-old coffee enthusiast, he calls himself. He works at a coffee shop, and he was cleaning his own gun when he accidentally fired it. As you see, there's a comminuted MP joint. The sensation is questionable. So when I see patients like this in my clinic, after it's being washed out and closed, usually, I give them 2 articles. One is why I hate index finger. And the other one is less than 10, talking about the stories of hand surgeons or surgeons in general who are missing a digit or 2 and how they can really able to cope with their lives. So my I wanted him to know about this because just keeping this index finger is always a big question for a lot of people. And he wanted to keep it. In that case, obviously there's some remnant of this phalangeal right here that you see that can be plated. Intraoperatively, I realized there was another split fracture, so I immediately went into a spanning plate fixation in addition to bone grafting, as you've seen here. And once again, going through the principles at the MP joint, the screws on the lateral plane or the AP plane is located where they are, as you see through the poke holes that you create. And then the plate comes in with a little space between the extensor tendon and the plate. The best way to achieve that is to use a locking plate and insert your freer right under that and lock your screws in that position. Come back up. The functional result is not, oh, okay, I forgot to enter that one. Sorry about that. Yeah, it's not there. Anyway, this patient went on to healing and reasonable range of motion in terms of the MP joint, and happy to keep his finger at this point. There aren't many reports on this particular subject other than the index procedure. I'm hoping that new generation of hand surgeons will apply this more often. But there's one thing that's common among those is that those reported case series is that complex peri and intraarticular fractures and fracture dislocations are ideal candidates for this type of fixation. Or if you have a patient who are not good candidates for the X-fix, those are also good candidates for it. And with that, now, thank you very much for your attention.
Thank you very much. I think those are some really good tips and tricks. Again, it's a tool that I don't think that we have to employ very often. So I think your comment of hopefully you don't have to do it very often, I think it rings true. But there, I can distinctly remember a few times where this was the only option. And I wish I had known those tricks in particular, not to crush the extensor mechanism, because going dorsal is much easier than trying to mold the plate to go lateral. So that was excellent. Thank you very much. Thank you very much to our speakers. I think that the overall presentations were so comprehensive. Hopefully, to all of you who spent some time with us today, have a little more courage to take on these challenging fractures with some of these tried and true methods, but also you may want to try some of these innovative methods as well. So thank you again also for the very lively conversation. I'll pass it off to Dr. Sonu Jain now, just to close out this webinar. Thank you, everyone.
Thanks, Peter. A wonderful job moderating. And to our speakers, I mean, those were outstanding talks. I mean, I feel like telling the ER to bring it on. I do want to thank you, the audience, for being here tonight, and would like to just remind you that we have an upcoming webinar in August, amyloidosis for the hand surgeon. And also to remind you that we have our upcoming annual meeting in January. Please join us for that. It's a brand new hotel down in Chula Vista, just south of San Diego. Both of these you can find at our website, handsurgery.org. With that, have a good night.